Good afternoon, good morning, everyone. We're going to present 3 different panels today. So Raj is here. Okay, we're going to start. So the first panel will be about oblique muscle dysfunction. The second panel will be about reoperations in strabismus, and finally the third panel about concomitant strabismus. So starting, we have a prestigious list of panels today: Dr. Ahmed Taha from Ain Shams University, Dr. Akbar Rizqa from the Research Institute of Ophthalmology, Dr. Helen Reyes from Cairo University, and Dr. Ramesh Kirtanai from the Albi Prasad. So we're going to start with a very straightforward case. So this is a 14-year-old boy presented with the art complications, right arm, and a history of bilateral medial rectus recession at the age of 1 year, and he presented later on with an A-pattern ectotropia, a bilateral severe oblique overaction, and you can see that they have some DVD, especially on the left side. So this is a classical case of what we call a Western triad. So starting with our panel, what would be the management to do for such cases? Starting from the left, from Dr. Ahmed Taha.
Such case, I if there is no incontinence in the medial rectus, I'm going to advance medial. If there is incontinence.
Okay, let's focus on just the vertical part with medial rectus. With the panel is about oblique muscle dysfunction. How are we going to manage the superior obliques and the DVD?
In here, if there is no change regarding oblique dysfunction, it's not consecutive, it was in from the start. I prefer to go for oblique muscle surgery for correction of this DVD and overaction. And sometimes, if there is any change about superior oblique, I will go for weakening superior oblique and superior rectus recession.
Dr. Akbar, do you weaken both muscles, the superior rectus and superior oblique in these patients?
For the medial rectus?
The superior rectus and the superior oblique in a patient with a Western triad with an A-pattern exit, would you weaken the superior rectus and superior oblique? What type of surgery would you do in order to correct the DVD and in order to correct the superior oblique overaction?
I will correct only the superior oblique overaction because we don't know the cause of the DVD. It's a limitation of depression in contraction.
So you would just do a superior oblique weakening, but you wouldn't attack the DVD at this stage.
So it will last a long time because if you notice that if you do the motility, you will find really limitation of depression in contraction. So it's a DVD or depression. So what you will do for the superior rectus will also again DVD.
Okay. Dr. Hel, what will you do in these patients? What is your strategy?
I do both superior oblique posterior and superior rectus recessions.
Okay, so you do a full muscle splitting lengthening procedure.
Sorry?
A split lengthening procedure. You do that lengthening of the superior oblique.
No, posterior tenectomy.
Posterior tenectomy only. Okay.
Only, yes,
Okay.
and recessions.
Dr. Ramesh?
Yeah, there are 2 things to take care here. One, this is an concomitant DVD. It's an concomitant DVD. So DVD, I don't know what's the angle of DVD, the amount of DVD in primary position. So depending upon that, I will put them on mild, moderate and severe category. And I agree with the other panelists where we will do a superior rectus recession, because when you weaken the superior oblique, the hypertropia can become more. That's why doing it is important. Whether to do a superior oblique tenectomy or posterior tenotomy, I will take care of force traction test and the torsional element on the fundus photography. If it is too tight superior oblique, I'll do a tenectomy. Otherwise, I'll do a posterior 7/8 tenotomy of the superior oblique. So I will do both. Thank you.
Dr. Hel, how do you calibrate the surgical dose when you have a DVD and you have a superior oblique overaction? And usually there are asymmetrical. The DVD is more in one eye and the superior oblique overaction is more in the other eye. So how do you calibrate the superior oblique weakening and the superior rectus recession?
Well, for the superior rectus recession, it depends on the amount of recession, and usually I do 8 millimeters for the lesser eye, and depending on the difference, I would add it to the eye with the more dissociative vertical deviation, and usually they are asymmetrical.
But the posterior sternotomy, you will do it equal on both sides, even if one eye have a more severe oblique action than the
Yes,
other eye?
I do it equally
You
on
will
both
do equal,
sides.
okay.
Yes.
So anybody in the panel will do a full oblique muscle surgery when you weaken the superior oblique and inferior oblique. Anybody would like to do this? No. Okay.
I don't do that.
Okay. So next case is the patient with classical right head tilt, and when you correct it, the head tilt has a left hypertrophy, and you can see that he has a left inferior oblique overaction, and with the three-step test, is a classical increase of the hypertrophy on left tilt, suggests that it's a left superior oblique flows through. And here is the measurement, has a hypertrophy of 15 present diopters that increased to 35 present diopters on right gaze. So this is a classical case. So what is the standard procedure we do for such case? Dr. Ahmed Taha, let's see how many of our panel will do a recession, how many will do a myectomy. Dr. Ahmed Taha? A recession, myectomy, or what? Just a classical left oblique with a left hypertrophy, nothing more.
I go for myectomy.
You go for myectomy. Dr. Akmal?
My plan, because I should measure the torsion. If I have vertical more than torsion or torsion more than vertical, so I isolate the inferior oblique from the insertion, and accordingly I do recession and anterior transposition. How much recession depends how much extortion and how much elevation I will do anterior transposition.
So here is the figure for the inferior oblique, Dr. Akmal. Where would you put the muscle? Let's say this is the inferior oblique. You are going to move it back. You are going to move it.
The inferior
Finger. Yeah. So this is the finger point. If you are going to move it at the same path of the inferior oblique, or you are going to transpose it here, like partial point, where will be the site of your suture?
Either I strengthen the superior oblique or weaken the inferior oblique. It depends. He is a young, so if he has orthophoria at up, I will do better strengthening of the superior oblique. Because I want
Let's assume he is a hypertrophy in primary position in up gaze. He has an inferior oblique overaction. He has no superior oblique underaction, is very minimal. So you're going to attack the inferior oblique. So where are you going to put your suture? In this figure, for example, like allowing the path of the inferior oblique, or you're going to do some kind of anterior transposition.
This is the So I will do you mind how much I can do? I will put it exactly if it is 4
millimeter?
Yes, 5 millimeter down and 3 millimeter anterior.
So this is a classical finger point you're going to use. Dr. Hel, where are you going to put your suture? I know that you're going to do a recession for sure.
So I don't do myectomies, and we always have this fight about doing myectomies. I don't like to do away with the muscle, and I don't like to do surgery that is not controlled and not reversible. So when you have 15 present diopters of hypertrophy in primary position, you know that you need only one muscle to correct this hyperdeviation, and an inferior oblique recession would do very well. So I place the anterior pole 2 millimeters behind the temporal border of the inferior rectus, and I place the posterior pole behind it. And I like to have a vertical muscle at the end, and this gets rid of the vertical deviation and makes sure that I don't get any anti-elevation.
So Dr. Ahmed will do a myectomy, Dr. Akmal will put it 5 millimeter, Dr. Hel will put it 2 millimeter. Let's see, Dr. Ramesh, where are you going to do?
Yeah, in this particular case, if it is only vertical deviation of 15, both recession and myectomy will work here. But my tendency in this particular case, because in the right gaze, it's going up to 35 prism diopters. So for me, it's only one procedure here, inferior oblique myectomy. Having said that, you can also get the correction of hypertrophy of 15 in the primary position with the simple recession as well. Only thing is the side gaze, they might have still. So I will do a myectomy here.
So Dr. Ahmed and Dr. Ramesh will do a myectomy. The only drawback of myectomy is that people always think that you are in a hurry of doing a myectomy, but I think it does the job sometimes. So sometimes it's reported that patients with inferior oblique overaction, inferior oblique palsy, might have a problems in the superior oblique. You might find that even the tendon sometimes might be absent. So the question for my panel, do you always explore the superior oblique muscle in patients with superior oblique palsy, or if the patient has a straight ahead superior oblique overaction, you ignore exploring the superior oblique? Dr. Ramish, let's start from Dr. Ramish. Do you always explore the superior oblique?
So, almost never, except when I do a force traction test, if the superior oblique is very lax, if I have to do two muscles, I will explore. Otherwise, in 60 to 70% of the cases, I also get an imaging done of the quasi-coronal orbit. That tells me the size of the superior oblique. So, I don't do it only if the tendon is loose and also the vertical deviation is more than 20 or 25. Then only I'll explore.
Any of the panel would explore the superior oblique routinely in every case?
Can I just add one thing? I agree with Ramesh about only exploring if the force reduction test is loose, but also if you find that there is a significant difference in the vertical deviation between the down and in position and the up and in position. If it's much more in adduction and depression, then I would explore it if the tendon is loose as well.
Okay. So we explored superior oblique, and you can find here that this is a very loose superior oblique tendon, so probably most of us would go for a superior oblique tucking. So how do we adjust and calibrate the surgical dosing tucking? Let's start with Dr. Akmal. How do you adjust the tucking in a patient with superior oblique palsy? What is the dose and how do you actually make sure that you did the correct amount? Dr. Akmal.
Yes, for tucking, yes, I explore the superior oblique from the temporal side, from the insertion, and I do tucking. Whatever tucking or resection should be the same. But the advantage of tucking that the tendon of the superior oblique is very thin. But I am always doing as my first procedure that the weak muscle is the superior oblique, so I will tuck the superior oblique depending on the age of the patient and on the force reduction if it is loose. Routinely, less than 30 years old, I can do tucking because I'm doing tucking not more than 5 millimeter. I'm not doing tucking too much because above the 30 years old, the absorption of the retroorbital fat very high, so the superior oblique tendon will be anterior and induce a pseudo-Brown zone.
Okay. Dr. Ahmed, what is the amount of tucking we do?
First, about 5 to 6 milli, but I have to check it with force reduction test at the end. If I feel it's like tight or something like brown, I might reduce the amount of tucking.
Okay. Dr. Helen, do you have a standard amount for tucking? And you know, for example, when I tuck 8 millimeter, it will correct like 8 millimeter?
Usually, yes. But the most important thing again is to do a force reduction test at the end. You have to make sure that the eye comes up above the midline, above the imaginary line between the medial and the lateral canthus. Otherwise, you will be getting a Brown syndrome.
So what would be the average amount of tucking we do, and how many prism diopters it would correct?
Yeah, I do not use any measurement. I used to do 8, 10, 12 and 14 millimeter. 8 means 4 on both sides. 10 means 5 on both sides. So now I use a mechanical model where just do a namaste. You just add together. This is what I do. I just holds like a namaste sign. That's it. That really helps. And also, I think one of us said that you also have to do a force traction test at the end. So the mechanical tucking is what is required. You lift the globe, lift above the globe, and then where it connects, just put a suture. So this is just like a namaste what we wish in India. That's all I try to do here.
But your endpoint, again, you do the force reduction test after, and the endpoint is to find that you were able to elevate the eye.
Absolutely, just about a mild Brown syndrome is what we aim
So moving to another patient, this is an 8-year-old boy presenting with vertical deviation of his eyes, perhaps it was irrelevant, and you can see that the patient has alternating fixation preference. So, for example, when the left eye is fixing, he has the right hypertrophy, and when the right eye fixing, he has the left hyper, and the hypertrophy is concomitant with either eye fixing, where the cervical ductal fixation, cervical ductal vertical deviation with either eye fixing. And if we try to examine the methodology, still the deviation is common. The hypertrophy is almost equal in right gaze and in left gaze, so you cannot tell whether this is a problem in which vertical muscle. And when you measure the deviation, it is almost equal, 28 ductal in right gaze and 30 ductal in left gaze. So this is more or less like a spread of contents after a vertical muscle or a oblique muscle pulse. So what would you do in a patient with a spread of contents? Dr. Ahmed, what would you like to do? What would you like to see in this patient? You cannot tell whether this is an inferior oblique or superior oblique pulsing.
Yes, I have an idea about the torsion.
Okay, we can tell you can. So this is the head tilt and the torsion. This is the head tilt. So the head tilt, there is an increase in left tilt. So this can be either a right inferior oblique pulsing, and it can also be a left superior oblique pulsing, because both of them will increase on tilt to the left side. So it's either a right inferior oblique or a left superior oblique. We cannot differentiate between them just because the vertical deviation was equal in right and left gaze. Usually we know it from the previous step, but the previous step was not that helpful. And if we did the fundus torsion, we have an intorsion on the right side and extorsion on the left side. So we're still not sure which muscle is the paralytic muscle.
Any chance for this test?
Sorry?
Any chance for this test?
He had actually alternate compression, he did not do the S3. So just a vertical deviation that is competent, it can be a right superior oblique and it can be a left superior oblique muscle. What would be your treatment plan? Sure.
I would like just to add another differential diagnosis for this, which is an atypical Brown syndrome.
Okay.
Because I kind of see that the limitation is a little bit more in adduction than abduction in the right eye, and the intorsion as well in the fundus. So I would add that, and my first thing would be on table to do a force reduction test for the superior oblique muscle.
Okay, so Dr. Hala will do a force reduction test, and when we did the force reduction test, we find that the left, amazingly, I diagnosed to the right inferior oblique, like Dr. Hala mentioned, but intraoperatively I find that the left superior oblique was lax, and there was a slightly higher left superior rectus muscle. So I did an exploration, and there was an absence of the left superior oblique muscle. What would you do, Dr. Hala?
So, this is where whenever you have this kind of situation, probably it's best to do an imaging. It can pick up the size of the superior oblique on both sides. Second thing is, in Brown, you will have a Y pattern, which the patient did not have. If you look at the 9 gaze, Y pattern is not there. So, when you have this, it's a spread of commitments most of the times, and since you have absence of superior oblique, probably I would do 2 muscles here, probably inferior oblique weakening and also a superior rectus tightness. Not that you have to do too much because you don't want anti-elevation in the left eye. So that's what I would do in this
You
particular
do the
case.
left inferior oblique and the left superior rectus, right?
Yes.
Okay, Dr. Hala.
So first of all, for the, I've had the opportunity to see a lot of atypical Brown syndrome. And again, when the atypical, when you have the insertion on the nasal side, you don't have the V pattern some of the time. So the having a V pattern is not really diagnostic when you have a nasal insertion of the superior oblique and Brown. And for me here, what I would do an inferior oblique nasal transposition and an inferior rectus recession of the right side.
Right side. Dr. Akmal, will you do something different?
Yes, if I confronted with the absent superior oblique, I will do the left inferior oblique weakening and right on the other side inferior rectus weakening. This is my preferred.
Change in the angle of deviation up and down. There is I mean, it's higher.
The patient has really common deviation, right gaze, left gaze, up gaze, down. They actually cannot use
There's
any
not much of a change going this and any direction than the other. I will go for inferior oblique weakening. I might go for superior rectus weakening in the other.
Okay, this is exactly what I did like Dr. Ramos and Dr. Akmal mentioned. I did an inferior oblique weakening and inferior rectus recession. I felt one would be helpful for the right gaze and the other would be helpful for the left gaze. But I got some overcorrection after surgery, and weirdly the overcorrection was on right gaze. The patient actually ended up with a left inferior oblique under action, as if I close to the patient a left inferior oblique palsy. As if the inferior oblique weakening was much stronger than what I should have done. So moving to another case, Dr.